Hi everyone and welcome to week 9. This week we're doing lumps, bumps and foreign bodies, and you are going to love it this week. The content is a little lighter. We have again no embryology, and foreign bodies or lumps, which are called a subcutaneous scan, are really quite fun, interesting scans because, like old Forrest Gump says, it's like a box of chocolates and you never know what you're going to get. You could get a multitude of different body parts that these lumps could be appearing on. One moment you could be looking at the back of the neck, the next it could be an ear, a jaw, a calf, a foot, fingers, hands, anywhere. So you really need to up your repertoire in terms of being creative and how you're going to do these scans, because like lots of things with sonography, there is not one set way in how we do this. So enjoy foreign bodies and lots of different lumps this week. It's quite a fun topic this week and I hope you enjoy it. So straight on to the two parts of the lecture. Again, starting with the anatomy and the physiology, looking at our normal sonographic appearance, not of the particular foreign bodies, but around the skin and all of the structures around it. Now, most of this should be a revision for you because you know all about the vessels and muscle layers and things like that that are likely to be surrounding the foreign bodies, or the lumps happen to be coming from those particular layers. The subcutaneous scan, which is what it is called if you are looking at the layers of the skin for the lumps and trying to identify which particular layer they're in, what your protocol is likely to look like. As I said, it is very, very different. It will vary from clinic to clinic, but if you have a bit of a systemized approach, then you'll always make sure you're being very, very thorough and finding all the last little remnants of that palm frond that someone came in that might have stuck in their finger. The pathology, we're going to look at the skin layer pathology and trauma to start with, and then in the second part we're looking at foreign bodies and all of the lesions that can be either benign or malignant. So you'll see some similarities again this week starting to come through from the previous weeks. So our anatomy and physiology. Hopefully this is revision for you from your first year when you had a look at all of this, but important for you to understand the layers of the skin and why certain lesions may appear in certain areas and where the most likely part is for you to be looking at, so that you know that you are selecting the correct probe that's going to give you the depth to see everything that you need to see to try and find. You're really quite a detective this week in looking for foreign bodies. It literally is like finding a needle in a haystack, so you really need to know where to look, and this basically is going to be your map of where to look. So layers of the skin, we're looking at the epidermis, which is that more superficial layer, then we've got the dermis over here, and then the subcutaneous fat layer. Now again, that's similar to the breast layers that we've seen previously. So the epidermis, hopefully you can remember that that is the thinnest layer. As we can see up here, it's often where you're going to see tracks for foreign bodies. So you may not actually see the foreign body, but you'll see these anechoic little tracks of fluid that are going through that very, very superficial layer. So you know, hopefully skin layers, they're for protection and for covering, and that's basically where you're going to see some signs of damage as well. You might see slight thinning of this layer in slightly older people as they age. Age isn't good for the last couple of weeks, is it? And so this layer will be slightly less thick than what you will see in younger people. So going on to the dermal layer, and that's where all the action is. As we can see from the diagram, everything's going on. So we've got obviously the hair follicles. They can be infected and you'll get sebaceous cysts occurring, particularly in younger people and teenagers, where they get infected, and that's all going to be happening in that layer. We have the cells in this layer as well, which are responsible for temperature regulation and epithelial cell renewal, so making sure that we're constantly getting new cells all the time that are regenerated. We make sure that we have a good look all the way down to this layer, because anything that we see, new cells, any changes in cells which are mutated from new cells, are going to come from the bottom and rise up into the top. And that's basically how the life of that cell will work, in that they start from the bottom and then they start working their way up to the top, where then they are sloughed off, and then it all starts all over again. Oil and sweat glands are in this layer as well. So we've got one little purple curly sweat gland here. I haven't got an oil one in there, but that's also going to be areas, that's why we get sebaceous cysts, because that's where that oily layer, as you may recall from teenage years, is where this all stems, and where you can start getting some of those infected lesions occurring in this area. Now, soft tissue lesions are often found in this area as well. Now, they can be malignant or benign. So all of your different cells, like your melanocytes and all the keratin producing cells, are all in there. And when you've got such a huge variety of cells that are packed into that one area, they can undergo change because of either that cell renewal, where they undergo mutation and can be malignant, or because of damage, and that can be sun damage, or damage from being hit by something, for instance. Then finally we have the bottom, or the most posterior layer, which is the subcutaneous fat layer. Now, that's going to give support for that dermal layer, and as we all should be able to remember, that fat is stored for energy as well. So we know what the fat layers are going to look like because of a lot of the images that we looked at for the breast, and it's quite similar. You've got that hypoechoic region with the striations in between, but we'll have a look at some more images a little bit later on. So normal sonographic appearance for the tissue and the surrounds. So the subcutaneous tissue, remember, is really superficial. So it's that fine layer. It is in layers. It is horizontal, so it goes along there and is very fine, very thin, and it needs to be homogeneous. So sometimes it will be slightly hypoechoic. In older people, it can start to get a little bit sort of hyperechoic, but you're going to see it should be homogeneous there, nice and thin and nice and straight. You can see there's no sort of any lobulations or anything occurring there. So it's important to really have a good look. Sometimes the poor old subcutaneous layer is forgotten. It's very important if you're looking at abscesses or something, that you can always track to the surface to look for a punctum where it's going to be trying to exit through the skin layer, and that will be visible on the outside part of your skin. We see fascia around here, so it's not as easily appreciated here, but we can see it down here a little bit. We can see some layers of fascia along here, which are those echogenic strands, and they're going to separate those muscle layers around. So just remember that. We'll have a little bit more of a look at some fascia a little bit further on, and as I said, they're hyperechoic, again horizontal strands, almost like those fibrous strands. Now, muscles are going to be striated. I've got some great images of muscles a little bit later on in long and trans, so I'll talk about that then. Vascular, you've seen what the vascular vessels look like from the CCAs in the thyroids that you've been looking at, so you know that they should be totally anechoic. We don't want to see any echoes whatsoever, and if they're venous, they're going to compress and be slightly softer, a bit like that IJV that we should not have too much pressure on when we're scanning the thyroid. So and the arteries themselves won't change shape whatsoever. Now, something that is new this time is what a nerve looks like sonographically, and they are really cool little structures because they come in these like little round or ovoid packages here, and they're called salt and pepper. You need to be looking for the salt and pepper, and sometimes it's a bit hard to see unless you are scanning dynamically, but it's almost like they look like little fascicles, and you'll see these anechoic little like cystic type spaces around. So this is the nerve here, and when you are having a bit of a look at your hand, you'll be able to see the median nerves and radial nerves really, really nicely because it's so thin. So if you're ever having a bit of an explore, take a look and see if you can find the median nerve. So this is what a nerve looks like. Salt and pepper, have a bit of a look. And lymph nodes. Now we all should be absolutely perfect at recognizing what lymph nodes look like, so I'm not going to go into any more detail. Because muscle, we haven't really had a good look at muscle. So this image here is in transverse and this is in longitudinal. So remembering from your anatomy days, and hopefully this is all so fresh in your minds after year one, you'll see the layers are in long striations, and we can see the depiction between the two different muscles because they actually are traveling in sort of those slightly different directions there. And here we can see that echogenic fascia, which is the borders or the areas between demarcating the two different muscle layers in between. So you'll see those horizontal striations of fascia in between. Here we can see it in transverse. Here's the fascia cutting through here. So that's again echogenic, nice echogenic striations. And then these fibers that are lying horizontally here, we can see are rounded, so there you can actually appreciate all the little tiny fascicles that hopefully you can remember what build, or the bundles that build up a muscle and what they look like. So that's what the muscle looks like in case you are looking for any type of hematomas or lesions within the muscles, or you could have penetrating injuries that have been removed and have left little shards that are cutting across those layers in a different direction in terms of maybe a foreign body, for instance. So that's muscles. What about the scan? Well, as I said, could be anything. Could be the neck. You could be doing somebody's back, their finger. It could be bony structures around the elbow, anywhere that we can basically hit, get hematomas or bruises, or something could sting and leave a sting left in. Anywhere in the body we could be looking at. So again, we do have to be creative. So what do we need to use? Have to use the probe that's going to be most appropriate for what you're looking at. If you're looking at, and I've seen some very big lumps in my time, you might need to take a big linear 12. Now a lot of the nice new machines have got those high frequency 17 probes, and they give you some beautiful clarity in your images. But remember, the higher we go with our frequency, it means we're not going to get that penetrative depth. So you've got to really decide whether or not you're going to be able to use that. Other than that, for small little things like palm fronds, glass, shards, anything that might be stuck in fingers or somewhere, we're going to use this little hockey stick. And it is named because it looks like a hockey stick. It is a linear probe, however it's not curvilinear or anything like that, and it's quite a tricky little probe to get used to. You must use loads and loads of gel. We can see here, just like we did on the eye, how much gel we need to use so that we're covering all of those bony structures. And because we're looking at skin in some areas, like particularly fingers, where we've got lots of little dimples and folds in the skin, that's all got to be filled up, a bit like polyfiller, filling it all up so that we've got that nice smooth area that we're going to be scanning. Now, something that you should have in your top drawers in your labs are standoff pads, and they're little round ones. They're usually disposable, and they are just like a preset circle of gel. They can come in squares, they don't have to be in circles, and they're around about that thick, and they just are like a big blob of gel that's set and commercially made for you, so that you can actually, if you've got some bony structures, you put the standoff pad over the top, and then you've got a really nice surface, and you can get some really great contact, and you don't get all of that drop out. So consider a standoff pad if you're going around elbows, bony areas. It feels a little bit for the patient like a wet frog, so you do have to warn them that it may feel a little unpleasant or a little bit cool, but the images you get with them are really worthwhile. But because it's increasing that depth, you do need to make sure that you've got enough depth with the probe that you're using. So there's that trade-off as well. Dynamic scanning, very important, because foreign bodies migrate. So if they've been there a little while, they don't tend to just stay put, unfortunately, and they can migrate to different parts or distal parts of the body, or they can be actually traveling up towards the heart. So you need to be dynamic with your scanning. You don't just get the patient to point at the lump, and remember, we've talked about that before. They'll say, oh, it's around here somewhere. You really want them to feel for it, put their finger on it, and make sure that they tell you in a couple of different ways. So you might go and do something else and then get them to put their finger on, because I've found with a few patients that they'll say it's here, and then the next time it's like, oh, it's here. It kind of moves a little bit. So get them in a few different ways to explain or show you maybe what they were doing when it happened, so that you get them to point out that spot a few times, unless of course there's a big marble like structure that you can definitely see straight away. So I often put a little marker on the area, so I don't have to keep asking them where it is, because it'll usually, if it's a splinter or a palm frond or something, it'll be a little bit sore. It may not necessarily always be red, and some of the lumps that patients can feel are so barely discernible. Sometimes you just put a little spot or a little X there so that you can just put the probe directly on there. Make sure then that you're also scanning well past any joints to make sure that you are checking for any of those migrating foreign bodies, or there could have been a piece of glass or something that had some shards break off. So you could be actually looking for multiple foreign bodies rather than just one. So you need to be very, very thorough and systematic in what you are doing. Of course, always going to be doing that survey in long and trans with a very, very, very light touch, so that you're not going to be reducing any lump if they're palpable. If they're fluid filled, if you're pressing too hard, you might actually be squashing it and miss seeing it all together. Or if it's a fluffy little lipoma, you won't be able to appreciate it very well if your pressure's too hard. You can use that graded pressure as well to try and determine whether it's a fluid collection as opposed to a more solid structure, or it's some type of fibrosis as well. Scanning the area, as I've said, get that patient to palpate the lump exactly for you, makes it a lot easier, and mark it as soon as you can. Now, for your comfort, you should be either standing or sitting, and you're going to have to change that depending on the area that you're looking at. So keep in mind, it's not just the comfort for your patient though, it's comfort for you. So you need to be feeling quite comfortable with your scanning. Now you can also use pillows and wedges. Sometimes, especially if you're doing hands or wrists or fingers, you can get the patient to have the pillow on them and just resting their hand on top, and it makes it a perfect height for you. Use the bed to go up and down, all of those sorts of things, so that you're using absolutely perfect and beautiful ergonomics, and you will thank me in 20 years when I'm in my nursing home. Apart from that, body markers. Now, we have used body markers when we were looking at the breast in the labs that we've done, so please have a look at what body markers are available. When you just press them, they'll all come up, and it really helps to let your radiologist know the exact part. As you can see from some of these images, it's just a shot of skin or of subcutaneous fat. It could be anywhere. So it's very important that you can try and put those body markers on and show where the probe happens to be. It's one of the few scans that it's difficult to actually see whether or not you're in long or trans, particularly with a hockey stick. Very, very difficult to determine the difference. So use those body markers. Or you can use known landmarks like a joint. You'll see a nice rounded bone coming off. Similar to how I get you in the thyroid to have a little bit of thyroid tissue on there and where the CCA is, so that we can see where the C chain is sitting nicely. So try and use some landmarks or joints or vessels and label them, so that your radiologist has got an idea where on earth this area is that you have imaged. Watch your focal zones for that depth. Like this one here, it needs to be at least at the level of the foreign body or posterior to it to get that depth. Why? Because with foreign bodies particularly, you're going to have artifact, and you need this artifact, and you can see it all over here, to help you determine what it is. So don't chop off the artifact, and give yourself enough depth and get that focal zone right to assist you. Also, be aware of that artifact mimicking lesions or foreign bodies, so it's a bit tricky. Some of you hopefully can remember from some of the things we've looked at before, but this is glass down here, and you can see it looks like bubbles trapped in air, but it's actually a foreign body, so not bubbles at all. And what other things can we have that look like air trapped in something? And hopefully you've read or seen where abscesses can have that air filled and gas filled structures, so it actually could start looking, you think, is that an abscess going on there? Also, we've got calcifications over here. These look like calcifications. They're actually foreign bodies. So you need to be very aware of what they look like. Little gunshot pellets and things. Scary but true. These are some of the things in an ED department that you might see. So they can look very, very similar to a calcification. So be aware. Really, the best thing to do is look and look and look at lots of different materials and how they look at on ultrasound, so that you've got an idea of what they might be looking like. So imaging, panoramic, have a bit of a play with panoramic next time you've got a moment in your designated time for scanning, because it is a bit tricky. You can tell the difference because it has these little striations up the top here like a little picket fence, and it gives you a great image of particularly a large lesion like a hematoma that extends over a leg, for instance, a big area. So instead of having to dual screen and try and take a few images so that you've got measurements, doing a big panorama like here, you can see the calipers here, get a nice accurate measurement. Don't forget, you also want your measurements of your lesion in your 2 planes and your 3 measurements, as we always do. 2 are in long and then the width in trans, but also you'll need the measurement of the lesion or the foreign body from the skin surface, because if they're going to attempt to maybe dig it out or send them to their GP just to have a sort of a surgical incision, they want to know how deep that they've got to actually go to try and get that out. So very important how far that foreign body or lesion is from the skin surface. Other things that you're going to be looking at, harmonics and compounding. Of course, harmonics, if it's looking like a fluid-filled structure, that's not going to help you if it's a solid structure. Colour and power Dopplers to assess why are we going to use that. What does this lesion look like? Well, it could be a hematoma, it could be a cyst, it could be a few different things. It's difficult as well to tell the difference between a skin type cellulitis and skin edema, and one's infective and one isn't. So what is power Doppler or colour Doppler going to do for us? Hopefully you can remember that already. It's going to tell you the difference with the vascularity. So if it's an infective response, so if we're looking more like an abscess, for instance, or if it is cellulitis, it's going to have that vascularity, whereas the other isn't. Now, a little bit later on, you'll do more to do with vascular and spectral traces, so that you can tell the difference between a vein or an artery, which is very important if they are doing any other surgery that's going to occur. But I'm not going to talk a lot more about that. I don't want to get you too confused. You'll do that in third year. So our protocols, location, again, we talked about body markers, whereabouts it is. Think about how you're describing where it is, comparing it to the other side if possible, particularly with muscles. If you're looking to see if a muscle looks like there's some sort of fatty infiltration going on, or some bruising, which is going to be hyperechoic, you want to look at the other side, because it can actually just be normal for that person to be slightly hyperechoic. Always check with the other side if you can. Now the size I've already talked about, millimeters, centimeters, volume, long, trans, anterior, posterior, and that distance from the skin surface is very, very important. Echogenicity, homogeneous, heterogeneous, all those sorts of things. With texture, echogenicity, if it's anechoic, hyperechoic, all those types of descriptive types of words. We've looked at mass effect before, so whether it's actually moving between the layers, and we've talked about the skin layers, so you should be all experts about that. Compression I've just talked about as well, so whether they're going to be vessels, if they are arteries, veins, if that compression will come down into a vein. If it's a lesion, compression, just like the breast lesions we've done, is it going to be solid or is it fluid filled, using that dual screen with a compressed view and a non-compressed view. Shadowing is important for foreign bodies. We'll talk a bit more about that. So whether you are seeing that posterior shadowing to indicate that it is a foreign body, and vascularity, which we talked about, to show whether there is some infection going on there. So I did talk a little bit about skin edema. It has little or no vascularity. So you'll see it's all in this superficial area here in the subcutaneous fat, and it's going to be hyperechoic. It's the fat lobules there start to get this very hyperechoic look about them, and as they come down deep, the layering is going to be separated by this anechoic fluid that we can see in between there, and then it starts to get a lot more superficial. Very, very typical of edema, and you'll see it a lot with your patients who come in for a query DVT. I just did a load of them on the weekend, and the calves were larger than the thighs because of all this fluid. Means the skin on the outside becomes really tight because there's all this fluid there, and those poor patients can also end up getting all this scaling and the ulcers on the legs, which just don't seem to heal because of all of this that's going on. So quite painful for them, lots of fluid, and because it is static, it's trapped there, it's not going to move. So unlike if you're looking at any sort of joint fluid like that synovial joint fluid, or in bursa or something like that, where you can see the fluid moving around, or fluid levels in abscesses, this fluid's not going to move if you get that patient to move, or if you're pressing at all. So this isn't free fluid, not going to move, and there's no change with any graded compression, but it will be quite a bit sore, so you're not going to be doing a lot of graded compression anyway. But let's look at this very, very superficial layer here. It remains unchanged. You can see it's slightly hyperechoic, which is nice and normal. It's nice and thin, nice and horizontal and straight. So it's all in these deeper layers here. So then we have cellulitis. So there's the skin edema and cellulitis, where it's actually an infection, and that's what I was talking about before. We need to have that colour Doppler, because you can see how similar that looks, but very, very different processes. So it's from an infection, streptococcus and staphylococcus, or strep and staph, and it's really concentrating in terms of trying to tell the difference is between this cobblestoning. So you can see that the fluid actually surrounds the little fat lobules around here. So you can see that it's starting to look like it's separating a little bit. It's ill-defined, quite hyperechoic fat, even though here it doesn't look quite as hyperechoic as what it normally does. This is very, very early stage, but your tissue planes will be a bit blurred. It's really quite difficult to see, but it's hypervascular. So if you put some colour on, because it's an infection, you're going to see that vascularity coming in, and it's a precursor to an abscess. So if it's untreated, it then can go on to an abscess, which is here, similar to what we've seen before in abscesses. So very irregular margins, it's fluid filled, so you're going to see that hypoechoic region interiorly, and then the posterior enhancement, so making sure that you've got all of that depth happening. Some of them will have the fluid level, which we've talked about before, so you'll have that horizontal line and that layering, which is going to move as the patient moves. This looks a little bit more like it's resolving, and the fibrin is starting to heal, because it looks a little bit more like it's not going to be moving, and it's stable. So have a look for the fluid level as well. The squish sign. Now, an abscess is going to be very painful for your patient, so you're not going to be poking and prodding very, very much. But the squish sign is actually just with a little bit of pressure that we're going to see these echoes start swirling and moving around a little bit inside. Now that rim, because it's an infection, as we talked about, is going to be vascular, and it's a discrete structure, so we're going to see it, even though it's not as obvious in terms of the margins. You're going to see something where obviously the abscess has started, and it sometimes makes its way superficially towards the surface, and some of you may have seen when an abscess has actually been popped. unfortunately. So have a bit of a look at the differences. Hopefully this is all starting to come together from the other information that we've had over the preceding weeks of trying to layer it all. And I know it seemed hard going at the start, but now it should be like, oh yeah, we know all about that. So it gets so much easier the next few weeks for you. Be aware of the appearances of an abscess though. Look at that. That looks just like a cyst. Now, how are you going to tell the difference between that and a cyst? Straight away you should be saying, I would be popping on some probably power Doppler, because they're going to be lower flow in an abscess, and I'm going to see that peripheral vascularity indicating that there's an infective response, and I would say that is perfect. Finally, trauma. Oh, who hasn't banged themselves and hit themselves and got a nice big bruise or a big egg somewhere? I think I've done it so many times. Anyway, I digress. Hematomas, often really sore on the old funny bone, and you'll get this big fluid filled structure starting to occur, and it starts almost growing before your eyes. So it also changes on the inside over time. So essentially when it starts, you're going to have it very, very echogenic fluid, and it almost looks partially solid. It's going to be very, very painful then too, so you're not going to be prodding around too much there. As it starts to heal, within 6 hours, it's starting to, all the processes are starting to go on, and we're going to have that liquefaction again. So it's starting to get that clot, that anechoic look, and then we can start to see the appearance of fibre in those fibrous strands, very faint. So you might need to turn the gain up just a tad to see some of those fibrous strands. So that would be around the 6 hour mark. From 24 hours, it's starting to make those formalized components starting to come through as it's grouping to heal itself. So we're going to get solid, that mixed appearance of solid and cystic. It's all going to start to be a little more irregular in its shape because we've got those fibrous strands and that fibrin coming through. The scar is starting to occur. So as you go towards those superficial layers, that subcutaneous layer, don't forget poor old little subcutaneous layer, or that superficial layer, that very, very superficial one I talked about. Don't forget to look at him, because sometimes you'll see, remember when you get a little bit of a scab forming, the skin draws together, it pulls it all in. So you're going to actually see that retraction of the skin in that superficial layer there. So you'll see those low level echoes as the clot's starting to resolve, and you may see sort of little bits of the fibrous strands flicking in and out there as it starts to look a lot more solid. So it will change over time. It's not all going to be exactly the same, but be mindful that in those first few hours, particularly in the first day, it's going to be quite painful. So gently does it is really the guide for you. Time for a break. On to the next part. As I said, nice and short, hopefully for you this week. So I'll see you for part 2.